All right. Cause of death and age of death in public health. First, we need some data, so let's go get it. F5 isn't going to get me anywhere.
The clicker is on the top.
Mm-hmm.
Turn it the other way.
Oh. You're not the only one who's dangerous around here. Okay, so we get our data from death certificates, and they're legally required documents. We believe we have about 99% of the population covered. So it's actually more of a census than the census.
Nuh-uh.
Well, we don't have the name. I'll just point out a few of the things that are on the death certificate. The manner of death is one of the first things noted, and our options are accident, homicide, suicide, legal intervention, and natural death. Accident, homicide, suicide, and legal intervention are also called traumatic causes of death, or sometimes external causes of death, and natural is everything else. The accident, homicide, suicide, and legal intervention are determined by local coroners, and it's usually a medical professional, almost always a physician, who determines the natural cause of death. And in the cause of death section of the death certificate, we have a checkbox for the manner of death, four lines for the causes leading directly to death, one box for other significant conditions not leading directly to death, but still contributing. And oddly enough, they're called contributing conditions. Then we have a box for a description of the injury, if there is an injury, and a checkbox for the contribution of tobacco use to the death. The physician is asked if tobacco use contributed to the death, and he can say yes, no, probably, or I don't know.
How long has that been on the death certificate?
That's been on the death certificate since 2003. We haven't always had that, but it's...
Is that a Montana thing or a national thing?
That's a national thing, actually. It's every few years the federal government makes recommendations to the states on what we should have on our death certificates, and Montana adopted all of the recommendations of the feds. And as I said, we use this information to measure the burden of disease. Every literal expression and checkbox item on the death certificate is reduced to an alphanumeric code, and through a process called nosology, something I'm not trained in and is sort of magic, is an underlying cause is chosen from among those. And I have a couple of examples here. We will go through them. The first one, the manner is determined to be suicide. On the first line of part 1, we have drug overdose, morphine. On the second line, depression. The third line, chronic pain, and there's nothing on the fourth line or in part 2. It's an overdose in the description of injury. So you read that as drug overdose or morphine overdose due to depression, which is due to chronic pain. And then tobacco use did not contribute to this death. And as you can see, an alphanumeric code is assigned to each one of those entities, as they're called, and the underlying cause is chosen to be X62, self-poisoning by narcotics and psychodysliptics. In our second example, manner is natural. On AB we have sudden cardiac death syndrome, I-461, and rheumatic heart disease, I-099. In part 2, COPD, chronic obstructive pulmonary diseases, is noted, and so is the history of colon cancer. And there are 2 codes there, one for each of those entities. Tobacco use did contribute to this death, and the underlying cause is determined to be I-099, rheumatic heart disease, unspecified.
Would that history be with the individual or in the family? Just
That,
strictly with
that history would refer to the
Just this
individual.
person.
Yeah, just the person, the certificate.
And what does the unspecified mean?
Unspecified means that no further detail was added, and some physicians will, and some will not. I mean, this is some of the imprecision in death certificate coding and the categories that arise from it. Not all in the scientific studies that we all learn about at school. There is a protocol, and everyone follows the same protocol. We have a crop of physicians and coroners out there who all have different professional experiences, different educational experiences, and some will be more detailed than others when it comes to describing a death. So anyway, this is where our categories come from, and here we're listing the leading causes of death in descending order. This is a traditional way of measuring burden of disease. As you can see, cancer and heart disease are leading the pack by quite a bit. CLRD means chronic lower respiratory diseases. That's virtually the same thing as chronic obstructive pulmonary disease, and that's asthma, bronchitis, and emphysema, essentially. Then cerebrovascular disease, non-motor vehicle accidents, and I won't go through all of them. I'll just note that in most tabulations and graphics that you'll see from the federal government on cause of death, they put non-motor vehicle accidents and motor vehicle accidents together and list them that way. I broke them out for today, and I have been doing that for several years because a lot of people simply want to know about motor vehicle accidents and their role in the picture. I've also included a few things that you won't see as a leading cause of death in most tabulations: sudden infant death syndrome, perinatal conditions, which Carol mentioned earlier, congenital malformations. Essentially, those are birth defects. Well, actually, I guess that's about it. HIV infection. That wouldn't be a leading cause of death in this country. But the coding scheme we work with is actually an international scheme. And while HIV doesn't take a big toll here, it kills a lot of people in Central Africa. But we can go a little further than that. An alternative method for looking at burden is called years of potential life lost. We simply subtract the age of death from an arbitrary number. We use 75 here because the federal government also uses 75. And we strive to make our statistics comparable to theirs so we can measure our performance, or status, I should say. Then we simply sum those by category, ignoring the negative numbers that come from people who die before or after the age of 75. Now, this is I guess you'd say, an untraditional way of ranking causes of death, but you can gain some insights, I think. And, well, I'll just show you the next picture here. You can see cancer and heart disease are still ranked first and second, and that's because a lot of people die of cancer and heart disease. And here we're counting only those that died younger than age 75 and the number of years each one gave up. But with so many decedents, even a very small number of years adds up. But what you should notice here is that accidents, both motor vehicle and non-motor vehicle, start to stand out more than they did before, when we were simply looking at the frequency of death.
Hey Bruce,
Yeah.
is that a product of teenagers dying in motor vehicle accidents? So 75 minus 15 is a bigger number than
Yes.
75 minus 55?
Yes, you got it. Yeah, that's very much the problem, the issue there. And you'll see that, well, both types of accidents, suicide, we don't have very many homicides, so homicide doesn't make a very big splash in this picture. But yeah, all those people die at a much younger age. Back in their 20s or 30s often. And I'm looking here again at the total years of potential life lost. But then I want to point out that we can break this out by race or any other demographic variable that we want: sex, place of residence, educational attainment. Those would all be very interesting, but I decided not to bore you with them or go to too much trouble. Okay, and here we can also simply divide the total years of potential life by the number of decedents below the age of 75 and come up with an average. And this shows us essentially how many years each decedent typically contributes to the total.
So from a public health perspective, this would be a way of, instead of just looking at causes of death and saying, ooh, cancer or heart disease, we should focus all our resources, all our policy efforts there, when it may be just the population is aging, so they're going to die.
Well, yes.
And this may help you identify some other areas that you may want to.
I'm really getting concerned with you. You old folks are going to die anyway.
Well, they are.
I'm
And
feeling
not saying-
them love.
I mean, they will.
Actually, that's
But I'm saying like 90, 100, I don't need 70.
Okay.
actually that's exactly what I had when I started doing all of this math, applied math. I naively thought that I was going to discover the way to increase total longevity in the population, but it's not. It doesn't work quite that way. In fact, I was talking to Carol about this a few days ago, and as is her wont, she brought me right down to earth and said, "Yeah, the motor vehicle accidents, for instance, the other accidents, those contribute a lot to total years of potential life lost, but the numbers of those events are so small compared to heart disease and cancer that they're almost swamped by those other natural causes."
And one of the things I find really striking about this presentation, which is average years lost, and then the racial comparison is, for example, motor vehicle accidents, the racial comparison for motor vehicle accidents, the racial comparison for suicide. It really emphasizes the disparity between white American Indian populations for those two causes of death.
Done? Okay. Sorry. You'll notice, might want to notice at the bottom there, towards the bottom, sudden infant death syndrome. Those people are infants when they died, so they each gave up 75 years of life, which is exactly what you see on the graph, and that's reassuring to me. It means I did something right. It means my arithmetic was good. Okay. Oh, that's a different subject. Anyway, I thought this would be an interesting statistical tool to help us think about causes of death and where to possibly concentrate resources. And I want to emphasize possibly because, the cancer and heart disease, for instance, are actually swamping the effects of accidents and suicide. Although I would say that the accident and suicide deaths are much more tragic. Okay, let's have a little fun here. This is the age distribution of the cause of the. This is the age distribution of death. Age at death, and I would like you to notice this is for 9 years, 54 to 62. The subsequent graphs will be for 10 years apiece. Notice the spike in infancy was 400 in those 9 years. So watch what happens to on both the left and right sides of the graphs. Death in infancy is going down, which is good. And people are living longer, and more improvement, and a little more improvement, and a little more, and a little more. And that's 2003 through 2012.
Yeah, but look at the spike in infants.
Right. It's still there, but it's much smaller. Our rate of infant death is like 6.9, I think it was, in the last period. That's about 75 a year.
Did you go back then? I must be missing.
It was way at the
It was way at the
top.
It was way up at.
Oh, that's why I didn't see it.
Yeah. It's
Yeah.
lower.
Okay. I thought it was just the edge of the graph.
I have these broken out by single year of age, and it's actually really cool to go through 59 different graphs like this. And this is the other component, the natural component that's contributing to the aging of our population, our falling birth rate. And I won't say much about this. I think it kind of speaks for itself. And here are the numbers of births, if you prefer to look at that rather than births per thousand population, which is what the rate is. We had 18,000 deaths, or 18,000 live births in the mid-50s. We're now down to about 12,000 a year. So, Cody.
See if I can remember what button to hit on this thing.
Okay.
Escape.
Escape.
When in doubt, escape. F5. Montana's future population and hospital costs. I think Cody Ocustis is me, so I get to do this one. And click on in. So there's our computer. Not really, but find
New
something.
iPad?
Yeah, the new iPad.
Okay, so I'll start by talking a little bit about what the Montana Hospital Discharge Data System does. Then we'll move on to how Montana's aging population is going to affect the healthcare of Montanans. So we're part of the Office of Epidemiology and Scientific Support, and we get data from hospitalizations. We have inpatient data going back from 2000 to 2012, and we expect to get that going forward. We have an agreement with Montana's Hospital Association. We got emergency department data that should actually be from 2010 to 2012. I typed in the wrong numbers when I was doing that. and we just very recently got that. I think we got the files from them 2 weeks ago. We're still loading them and making sure everything's the way we expect it to be. So we now have inpatient hospitalizations and emergency department encounters, so I can keep track of the two names. And similar to how Bruce talked about the death certificate, I want to talk a little bit about how we actually get our data. So you think about somebody's admitted to the hospital, you've got admission notes, you have nurses' notes, you have notes from the doctor, you have all these forms, and I'm going to say we do better than the census because we get everything based off of the billing form. And if there's one thing we know hospitals are going to be good at doing, it's billing.
I can see that.
So
Inflate the numbers.
there's actually this form called the UB04, and this is about what they look like. They're mostly electronic now, but they're based off of the paper version. And so we get a selection of items off of that. We get the dates of admission and date of discharge. We get a lot of demographic information about the patient. We get the county of residence. We know where people live. We get the age. We know how old people are. We get the sex of people. Interestingly enough, that's not always known. In some cases, that's young. In some cases, they just didn't seem to want to write that down. We don't get personal identifiers, and that comes up a little bit if people are, say, readmitted. If someone comes in for a condition, they're discharged, and they get readmitted, then we don't have a way to sort those out, which is standard with hospitalization data, something that happens nationwide. We get diagnosis codes, which we're going to talk a little bit about. We get procedure codes, so we know if a procedure has been performed on someone. So, as an example, similar to Bruce's, if the admitting notes are patient was admitted for complications from diabetes, including ketoacidosis, that's why they gave me the fancy degree, because I can pronounce words like ketoacidosis, then we just get the diagnosis code, which comes from International Classification of Diseases. And ICD-9, it's 250.10. ICD-10, which is what they use for death, it's going to be E11.29. So there's two different forms of classification. There's going to be a transition taking place on October 1st, 2014. And that doesn't affect anything I do in this presentation, so don't worry about it. What do we use this data for? A couple different places that we use it a lot within the department. A lot of grant applications, we need to know how many of this is occurring. A lot of program reports and topical reports, which are interesting things that we come up with. So, skip a couple of the grant applications. Program reports, state health improvement plan. We used a lot of hospitalization data goes into that, measuring burdens. Community health assessments, that's one of the things that we've done as part of accreditation is we have health data for all the different communities throughout Montana. We use a lot of hospitalization data to measure the burdens of morbidity. Burden reports that we submit to the CDC. So when we want to tell the CDC how are our programs doing, we measure hospitalizations before, we measure hospitalizations after, look at trends and the like. And topical reports. So a couple of things we've looked at are ambulatory care sensitive conditions. These are really neat. The Agency for Healthcare Research and Quality is part of the Centers for Medicaid Services, and they got together with University of California, San Francisco, University of California, Berkeley, Stanford University, and came up with a way of classifying hospitalizations that are based on not just if somebody's hospitalized for diabetes, but could that have been prevented through better outpatient care?
Wow.
So there's a whole big list of ambulatory care sensitive conditions. And this is some place that is really good to focus because it's something that not just we say something can be done to prevent this, but the smart people at Berkeley say something can be done to prevent it. Hepatitis C, we did one looking at how obesity affects hospitalizations. And my favorite topic, circumcision.
Is it everyone's favorite topic?
The two,
You can tell we're good.
It's a long-awaited report.
so the two interesting things about the circumcision report are that Montana Medicaid changed reimbursement policy up until about, I think, 2004. Montana Medicaid covered that. In 2004, Montana Medicaid said if a parent wants to have their male child routinely circumcised, they're going to have to pay for it themselves. And the rates went from about 80% down to about 40%. It's not a particularly expensive operation, but just even that, having to pay for it, you see a large change. The other thing is we released a report, I think in 2010, and I was looking at the reports that the federal government, CMS, is doing, and sure enough, a year later, they pick it up. So we think they're probably just stealing all our good ideas and not telling us. Okay, I want to talk a little bit about healthcare utilization. So how do...
Before you move on, are those reports all on your website?
Those reports are all on our website. They're available. I'll have the URL at the end,
Okay.
and that'll get you to our website where you can read the different things. And I forgot to mention the When Animals Attack report. We did one looking at animal house hospitalizations. And I really, really wanted to call it Snakes on the Plains. And our state health officer made me go with, what is it? Encounters for animals and hospital. It was such a lame title compared to Snakes on the Plains. We're going to look at how Montanans utilize healthcare, particularly through inpatient hospitalizations. There's other forms that are used, outpatient services, clinical visits, but I'm in charge of the hospital data, so that's what I know. We're also going to look at the demographic changes. So we've had a lot of presentations. Montana's getting older. How is that going to affect things? Just to give you a little bit of an idea about where we're at now. So we have about 90,000 admissions per year. And some of those admissions are things like routine childbirth. We like it when people go to the hospital for routine childbirth. Some of those are admissions for things that are very preventable. That's what the prevention quality indicators is about. About 15% of admissions actually fall under things that are considered completely preventable according to PQIs. And average charges about $22,000 a year. So we do get charges. And that gives us an idea of how expensive a hospitalization is. We don't get actual reimbursement, so I don't spend a lot of time worrying about it. I worry about the number that they tell me.
So you're talking about these charges. Are you talking about hospital charges, or are you talking about hospital charges including like surgeon as well? Because surgeon will
the surgeon would be bundled under that in UB04. Yeah.
So it's included.
The UB04 would. It should be.
Because
usually I just ask for a group of
I mean, they billing separately from hospital.
For an inpatient admission or an ambulatory... Let me get back to you on that.
Okay, because I'm confused right now. I'm sorry that
If the physician is a hospital employee or not?
Let me get back to you on that because I'm not 100% sure. Our contact, usually I say ask Roberta, who's our contact at the MHA, because she knows everything about this. And knowing all the needy, I know they bill, but I'm not quite an expert in medical billing, so I don't want to pretend I'm one. And I'm very undertrained in medical coding. I know a little bit about it. So hospitalizations, that comes from our data sets. Population comes from Census and Economic Information Center. I emailed Joe, asked him what was going on. He said, here's the estimates from Remy. Go work with them. So that's where all of my numbers are going to be coming from for population. And I just want to start by looking at, this is actually hospitalizations to Montana residents. And on this one, I broke it into 0 to 19, 20 to 64. I guess economists consider 15 to 19-year-olds in the labor market. I was like, I'll just say people 20 to 64 in the labor market. 65 to 84, and then 85 plus. And we're just looking at who's going on in. And one of the things to take a look at is kind of how big these bars are relative to each other. So these are the people who are working, which means they're going to be paying for most of everything, either directly or indirectly. And these are the other people that they are supporting. Here's Montana's population. Did she go by Barb or Barbara? Either. Barbara had the bars side by side. I decided to stack them. So we have 2012. That's the most recent year of hospitalization data, fairly accurate as to what's going on now. Population projections 20 years from now, so further into Montana's future. And that's probably when I'll be working and presumably making more money because I'll have more experience, so I'm kind of worried about that. And 2055, when I get to retire, so I get to be in this group up here. So going way forward. Maybe I should just start, planning for that group. So one of the things to really think about is, Barb talked about this earlier, really this group is not growing a lot. This group is the young people, fairly stable, but we see some changes on really the 65 to 84. And this 85 plus group is very small to larger and larger. That group, as a share of the population, is getting larger. So here we have hospitalization rates for all causes, just any reason people might go in. And if we look at them by age, you see 2012 data, 0 to 64, very low. This is per 1,000 population. So about 50. And a lot of that, too, is things that we want people to go in for. That includes routine deliveries. That includes newborns and mothers. There's 2 separate admissions on that. So this isn't necessarily all things that are bad. That's not necessarily a bad sign. If you've got this rate can reflect things that just are. 65 to 84 rate quite a bit higher. Looks like about 200 per 1,000 population. 85 plus. If you think about that, 300 per 1,000 population, about a 1 in 3 chance that somebody's going to be admitted to the hospital. And if we go back and we think about our average charges, it's pretty expensive when people get into the hospital. So this group right here, as this group's going to grow, that's going to create quite a burden on the healthcare system. Okay, just a couple things. So total hospitalizations in 2012, 88,000, 88 per 1,000 population total. 28% of those were for people aged 65 to 84 per 1,000 population, and 7% of those were to people aged 85 plus. So we kind of think about that. This group right here, about 35%. And that, if we think about that just from an economic perspective, those are a group that's going to be picked up by the working people, poor working people like me for the next 40 years. Total charges statewide, about $1.9 billion, 2012, $1,800 per person. But if we think about that, 39% of those charges were from people aged between 65 to 84 years. A lot of charges, and 7% are for persons aged 85 plus. So one of the things that happens is, if we put the rates and charges on the same graph, we see low hospitalization rate, low charges for people aged 0 to 64. This group right here, 65 to 84, higher hospitalization rate, they tend to have fairly high charges just because they go in for some fairly high charge procedures. So we think about cardiac procedures, that tends to be the 65 to 84 age group. And that's why you see, even though this group's much more likely to be hospitalized, their charges aren't that much higher than people aged 65 to 84.
Is there an effect of Medicare will only pay so much, so that's what they charge? Versus if you're under 65, you're not going to get that benefit, and so therefore it's assumably a working age population, so the hospital can charge more for...
Charges are actually, reimbursement is affected by who the primary payer is going to be. Charges are pretty much independent of that. So a hospital is going to do the charge. The way they are going to set up the charges is based on asking everything I know about the healthcare system. So you've got the primary diagnosis, and then you have secondary diagnosis. Those get grouped along with age and length of stay to what's referred to as a DRG. And the hospital is going to use their DRG grouper and set charges based on that. And those will be the same for each payer. Reimbursement may vary by payer. That depends on what the payers negotiate with the hospitals.
But charges vary by age?
DRGs vary by age.
So then wouldn't that essentially factor in, if they're this old, and the potential payment form is going to be Medicare or not?
It depends.
Just thinking the correlation would seem very...
Think of the DRGs are, think of if somebody's admitted for diabetes, then basically there's 3 potential DRGs you can get. There's with minor complications and with major complications. And age has some effect on there, but I'm not sure how much it goes in. To be perfectly honest, in DRGs, no one except for 3M Corporation is entirely sure how anything goes in. They're the ones who make the DRG grouper, and no one else can seem to figure it out. So it has, I think there might be a little bit of an effect, but I don't quite think it's That's not the main explanation. The main explanation is basically these people are going in because they have major procedures which have high charges, because they're at the age where they have major procedures who have high charges.
The
And there's
working population that's employed and has insurance through employers, their insurance companies aren't going to allow the hospitals to charge them way more.
Right.
The people that tend to pick up some of the burden are the folks who don't have insurance
Right.
or who have private insurance
Right.
that they're paying for themselves.
Right.
Yeah, and there's a little bit of a false line here between the fact that I have 0 to 64 and 65 to 84. The healthcare burden of people aged 54 to or 55 to 64 looks fairly similar to them, but they're not working, and I had to, or those people are still working. I had to split it somewhere. So really, it's you got to find someplace on it. So what are we going to do? We're going to project per capita utilization based on both hospitalizations and charges in 2012 to 2035 and 25, accounting for the change in population. So we're going to say, assume people who are aged 0 to 64 use healthcare the way in the future that they do now. The only difference is going to be, there's going to be a bunch more of these people, there's going to be a bunch more of these people. These people will be about the same population. So total hospitalizations and total costs, let's just go to the graph. I like graphs better. So if we go to total hospitalizations, we see 2012, 2035. We don't see a large change amongst people aged 0 to 64 because population doesn't change. But what we're going to see is these large changes with these groups, 65 to 84 and 85 plus. And more importantly, that share is going to increase as well. So right now we have pretty decent slice for 65 to 84 and 85 plus. By the time we get to 2055, it's an even bigger slice. My hand goes from that big to that big. And that's going to have an impact not just in terms of how hospitals do things, but in terms of how people pay for it. Because we're not going to have an increase in the working population to pay for additional health care. Charges, we see, because people who are older tend to go in for have more expensive hospitalizations, higher charges, we see an impact there. Already we see a lot of the charges are going to the 65 to 84 group and 85 plus group, and then we'll see that will get even worse or there will be a higher percentage in 2035 and also in 2055. Of course, I'll be in that group by then, so I'm all for it. Any questions on that part? So what I wanted to do...
It's sobering.
The thing too that I think we sometimes tend to forget is we think, well, Medicare pays for them. And we sometimes just think that Medicare magically exists, and I go, well, who pays for Medicare? Right. Somebody has to pay for everything. And I don't necessarily know, I don't necessarily know who the person is, but it has to come out of somebody's pocket. I don't think we can just send all our charges to Bill Gates. That might make things easier. So I picked 3 different diseases to kind of, as case studies, to look at what happens in more specific cases. So we're going to go through hip fracture, diabetes, and then we'll look at influenza pneumonia. So case study, hip fracture, very expensive, $35,000 per hospitalization in terms of charges. That was for 2012. There's ongoing expenses. One of the things about hip fracture is a very low percentage of people are routinely discharged for it. About 10% of people get a routine discharge, which means, you go home, go about your business. Over half of people are discharged to skilled nursing facilities, which is additional healthcare costs, and we don't capture any of that in our analysis. The other big thing about hip fracture is that it's preventable. We pick things that we can do something about. The main cause of hip fracture is falls, so you can go in. A lot of them occur at home. Scarily enough, a lot of them occur in public places. But we think about, anybody work as a nurse, do some of those direct services we talk about? Fracture preventive things like rugs, rail bars in bathtubs, those sort of things. So it's very preventable.
any data on the morbidity rate close to this event? I mean, there's a wives' tale. Once, if you break your hip,
You're gonna die.
you're going to die pretty quick.
Mortality rate.
Not morbidity, mortality.
We.
Well, guess what? Yeah, tick, tick, tick.
That's why I don't care about
I was going to say yes and no, and I'll tell you why. There's two reasons why. There's three reasons. The first is we do have mortality for people who are discharged, but if they're not admitted, if they die before they get admitted to the hospital, then we don't pick them up. The other reason why it's a little bit strange has to do with the way that death certificates code versus hospitals code. So hospitals are going to code the hip fracture. Death certificates are going to classify it as the fall. So it's actually a coding convention change that makes it a little bit harder to examine in terms of mortality versus
I think it'll
hospitalization.
be interesting because it's much more than just the hospitalization cost. It's the fact that it's ending life early.
Well, or even in the case of the, we really, like I said, because I do hospitalization data, we really don't have a good way to pick up skilled nursing home costs. But when over half of the people are discharged to a skilled nursing home facility, we know that imposes a burden on society. Although part of me is a devil's advocate, I'm like, if people just die from stuff, it doesn't cost us that much.
Let's just go back to not getting here and die.
Just make the statistics so much easier.
Okay, so
Die in the hospital, die in the ambulance.
yeah, ambulance charges aren't that high.
Or just don't get a life alert, lie there for a few days.
Okay, so
I'm going to start a new company.
So we want to look at the rates for the different age groups. So hip fractures, very rare for people aged 0 to 64. A little bit more common age 65 to 84. 85 plus, far more common. Once again, that's based on mainly physiological factors. When you're young, your bones are really, really tough. You've got a really good sense of balance, hard to fall. As you get older, you become more likely to fall and have a hip fracture. And now I've hit a button on this and things are acting weird.
I think you should put you at a greater risk of having a break.
So what happens here is you see 2012, about 1,000 hospitalizations total, give or take. Nice ballpark number. In 2035, we expect that's going to go from 1,000 to about 1,700. And the reason why is because Montana's population is going to age. So when we have these conditions that mostly affect the aged population, we're going to see the large increases. 2055, because the 85 plus population has grown so much, we expect to see over 2,000 a year. So
At $3,500 a piece, or $35,000.
$35,000 a piece, yeah.
But that's going to increase because as costs go out to 2012. So
Yeah, the other thing too is we're holding the health constant, which may or may not be a reasonable prediction, and certainly costs are something that we're not experts in terms of medical inflation or anything like that, so we're just holding those in 2012 dollars. So you can see increased hospitalization, increased cost to society. Next case study, pneumonia and influenza. For classification purposes, we always talk about the flu, but because pneumonia and influenza develop together and pneumonia is easier to classify, they get classified together. So nice little picture of a flu virus. Everybody will probably use the little hand sanitizer thing on their way out.
please do.
So utilization, $16,000 per hospitalization, so not as expensive as hip fracture. Couple things is it tends to have strong cycles. Everybody remember the horrible swine flu pandemic?
Which one?
The swine flu pandemic of 2009.
Oh, I thought you meant 1918.
No, that was the Spanish flu.
That was Spanish. You're right.
The other big thing about pneumonia and influenza, vaccine preventable. You can get pneumonia and influenza. We have a big thing, emails going around the state. You can get your influenza shot. You can get them at Safeway. How's that for healthcare? You can get that and pick up some beer while you're there. Here's a guy who was very unhappy to get his pneumonia and influenza shot. I should have picked somebody who was at least smiling for it. So another example where we have smaller burden on the 0 to 64 population, and a very much larger burden on the 85 plus population. Remember too, this doesn't measure incidence, it measures people who are hospitalized. So we don't know how many people get pneumonia and have a case of pneumonia and influenza and don't go to the hospital. We don't know people who are treated through the emergency department. We don't know people who are younger and miss work because of it. We just have the people who are hospitalized. So this is something where if we look at it, about 3,000 hospitalizations in 2012, and we see 2035, we'll see an increase in that, and then 2055, we'll see an increase. So once again, an example of something that mainly affects the aged population, large increases. So last case study I want to do was diabetes mellitus. So here we have a guy with diabetes testing supplies who looks very scared of them. Got these photos from the CDC website, and I'm thinking, can we have a guy who's happy to be testing, or at least...
We don't want them to be happy.
Or at least, no, we do, because...
They're testing. Well, I guess.
There's two things about diabetes. So there's lifestyle factors that contribute to it, obesity and lack of exercise, but it's controllable. So people who have been diagnosed with diabetes, they can watch their blood glucose levels, watch their insulin. So one of the big things when I talked about AHRQ and preventable hospitalizations is most of the diabetes hospitalizations are due to uncontrolled diabetes. They're due to people not monitoring their blood glucose sugar, not taking their insulin when they need to take it. So they're preventable. We don't like preventable hospitalizations. But in this case, if we look at the rates in 2012, we don't see a strong an age effect. We see that a lot of them are people aged 0 to 64. They're even higher amongst people aged 65 to 84. And 85 plus, they're actually a little bit lower. And
You don't get there if you have it? Is that why?
that probably is. So we don't expect to see a large increase. We'll see some increase in inpatient hospitalizations for diabetes, but not the large increases we do for some of the other conditions. And once again, we're assuming that we're holding everything else equal, so we're assuming that the risk factors for diabetes don't massively increase in the intervening time. So conclusions, once again, large increases in conditions that are going to affect the aged. Think of things like influenza, hip fracture we went through. We'll see smaller increases with the population, things with diabetes mellitus. So we'll see changes in terms of where healthcare utilization wants to focus. Let me give you guys the bibliography. So I got my population projections from CEIC. This is our website, which you should, if you just ask Google about Montana Hospital Discharge Data System, they'll send you right to us, easier than trying to memorize the whole thing. And of course, our hospitalization data is courtesy of the Montana Hospital Association.
So, Cody, how many different, you gave the presentation of 3, how many different ones do you track?
It really depends on who asks us. I mean,
Right.
we have all hospitalizations regardless of what the cause is. There's not anything specific we're looking for. Mm-hmm. And so, if asthma asks us about asthma hospitalizations, we'll answer that. If our state medical officer comes and asks about hip fractures, we'll go and give them some information about hip fracture. And we've used it, Carol constantly talks about, we get so many different things we've looked at.
Right.
And we've looked at MRSA, we've looked at routine infant circumcision, just
Animal attacks.
Animal attacks, kind of whatever questions seem to come up, and it can shed light on.
Yeah, these push out, and when I say we, I mean mostly Cody, push out surveillance reports between 4 and 10 a year on some topic or other in hospital discharges. It has limitations, but it's so hugely minor.
Do you have county level data, or is it only state?
We have county level data. To some extent, we're a little bit restricted because of our agreement with the Hospital Association in terms of releasing county level data, and that can be a little bit frustrating. Of course, a lot of times the lesson though is your county looks like the state, which usually ends up happening. It's occasionally frustrating to go, well, we have that, but we cannot do that. If you really want county or hospital-specific data, the person to contact is Roberta Yeager at the Hospital Association, because since she works for them, she has more ability to release data than we do.
We're not being coy, Gail. It's that the Hospital Association has agreements with the hospitals who submit their data to the Hospital Association, that this is proprietary business information that they will not release to third parties except us.
Right.
And so we have to abide by that agreement.
Sure.
If we
And-
But we could also try to straight with hospitals.
Yeah, that's the way that it
And
is.
we've had hospitals ask us for hospital-specific data, and if they ask us, we still have to go through the hospital association on it, because they are the data owner.
How about reservations?
We do not have reservation-specific information, and we do not collect. Race is not collected. There's been some work to pilot it, but part of the problem is it's insurance data. And truth be told, I don't think insurance companies want to know anybody's race. It's probably going to be nothing but trouble if they ever do find out. So that makes it.
Well, it's a unique situation in that they're really concentrated populations that have
But the
insurance
reservations don't overlap with the counties.
problems. No. That's what I mean. The reservations themselves are very unique and have a big impact on Montana overall.
Yeah, it's a little bit of a source of frustration with the universe that we cannot measure the different burdens by race.
But you do have location data, right, or the patient?
We have county of residence on patient. We've had zip code, but zip code doesn't line up with reservation very well either.
No, but
And even if you know if a patient's from the reservation, that doesn't necessarily tell you race. Because some reservations are very mixed, some reservations are mostly American Indian, and even knowing that it's 90% American Indian doesn't tell you if that particular patient is American Indian.
Yeah, I mean, it's the location that's the key, not the race.
Cody, I've got a question. All of this indicates that the cost to the public is going to be increased as our aging population.
The cost to somebody is going to increase. That's for other policymakers to decide.
Yes, but the diseases you put up there and things like that, you basically put out that diabetes is linked to obesity and that lack of exercise. I contend that most of those were. Is there any push by the state to push more of a non-sedentary lifestyle?
That's part of our strategic plan.
And the counties are doing things.
Yeah, it's one of the things, it's one of the things in the state health improvement plan that we hope everybody, whatever their role in health care and public health, will take on, and it's also part of the division zone strategic plan. The chronic disease prevention programs have a number of initiatives in that direction, both addressing existing adult obesity to help people lose weight and preventing obesity from developing